to other decision-making processes. And so this is Sabura, a children hematologist, believing now, at the beginning, thinking that we are not making the decisions are made above, but teaching her on how to use evidence systematically, transparently. She wants now guidelines on childhood cancer, but WHO doesn't have childhood cancer guidelines. So that comes to you. So global guideline is a local guideline, and what can you do? So we try to support countries, but there is a wealth of experience, and I hope also a wish to reduce global inequity in guideline development. But you can do it already by developing your guidelines in a way that the other countries can easily use, adapt, access. And not only guidelines, but the materials that you use, evidence to decision frameworks, not in PDFs. It's very difficult to translate to Russian, which is the language, in addition to Tajik, used in Central Asia. So, if you go back and think the ways that there are people in Central Asia who may need your guideline. And then innovation, we have been talking about a lot, and collaboration, and it really resonates with the topic of this conference. You have my email number, email address. So if you want to contribute and support, then please send me an email. We have a very tiny program. It's me. And I do not only guidelines, but other evidence-informed policy making. So so thank you.
Thank you, Margia, for that fantastic presentation. And just to touch on some of your sporting metaphors, I think you rode the bike very well, and you didn't drop the ball, and you've handed the ball over to all of us to make our guidelines more adaptable for others. So thank you very much. Now there is time for a clarifying question, if anyone has any.
Hello, hi, I'm Sarah Temin from American Society of Clinical Oncology. I was wondering, in the final adaptation, how much overlap was there from the original guideline? Were the answers really that different of what to do in the local context?
Yeah. So actually the starting point was that it started with prioritization. The guideline panel chose not to go with every bigger question, but came down to, I think it's 10 to 12 bigger questions. And I would say that 80% was really adoption, and only 20% were with minor adaptations, except for the first-line regimen, where they chose not to prescribe only the one concrete drug, but they expanded this to the broad group of this. Probably don't get this wrong. Probably get this wrong if I will mention this, but basically the same group that the dolutegravir is coming from.
So it's my pleasure now to introduce our third speaker, and our third speaker is Carla Suarez Weiser, and she's the editor-in-chief of Cochrane. She's a board-certified clinician and also has a doctorate in evidence-based healthcare, and has been working in the field since 1997. So I'd like to welcome her. Oh, I'm here. You sneaked past me. Thank you very much.
Thank you very much, Roberta. I just want to start by thanking the organizers for having the courage of doing this meeting, because it's really fascinating to meet people and get back to where we were many years ago. So thank you very much for that. And I would like to talk to you today about global health equity, an issue that demands our urgent attention now more than ever. As Roberta said, I'm Cochrane's editor-in-chief, and these are my disclosures. I think it's no surprise to any one of us that COVID has had a major impact on all of our lives and create many health and socioeconomic issues in all corners of our world. While no one remains untouched by the pandemic, we know that its impact has been felt unevenly in the global north and south, contributing to ever higher levels of global health inequity. The consensus now is that we must address these issues as a matter of urgency, but the question is how we can make a real difference and deliver improvements at both local and global levels. And I'd like to focus in part of the answers that I believe that is important, and they are collaboration, capacity strengthening, and giving people a voice. And I want to do so by giving you some real-world examples, both from my past and to the present. And I'd like to begin by sharing some stories from when I, as a young doctor in Brazil, and these stories that shaped my understanding of inequity and what are the areas that we have to focus to take care of that. So I'm just going to start with bring you back to mid-1980s, when I graduated in medicine at the Federal University of Minas Gerais in Brazil. And you can see if you're imaginative, you'll find me on these photos, and because it's a long time ago. But many of these people are still my friends after 30-some years. Around this time, the Faculty of Medicine has started sending final-year medical students to rural areas of Brazil for an internship program. And the idea was to provide us with hands-on primary care experience, but also to expose us to the issues of health determinants of health, social determinants of health. And from the outset, this program was really very innovative, practical, and important, especially given the socioeconomic disparities that are very common in my country. I was certainly a beneficiary of this program, and the experience that this program offered me continued to shape my understanding of the importance of collaboration, capacity strengthening, and giving people a voice to be able to support equity. Having grown up in a small fish village, this beautiful fish village here, the photo that you see here, I grew up in the coast of Brazil in the northeast, and in a very small village with 2,000 people. So I was quite acutely aware of the issues of inequities in my own country. But when I went to do my internship, I was posted in a city called Itaipé in the northeast of the region of Brazil, and this was really an eye-opener for me. The city in itself had a few streets around the church, but most of the inhabitants used to live in rural areas without basic sanitation or access to health and education. And the city today has 13,000 people, but at that point were less than 2,000 people. There was no healthcare facility. There was no resource to buy medicine and no diagnostic testing at all. So I really quickly realized that one of my first real steps towards improving healthcare in the community was to convince local policymakers to invest in a healthcare facility, to invest in medications, and to invest in diagnostic testing. But this was more easily said than done. The city was led by a very powerful mayor that also happened to be the owner of a distillery for cachaça. Now, it's not the oil that, that she mentioned. Cachaça is a very strong spirit made of sugarcane that is very common in Brazil. And it was well known that to do business of any kind with this mayor, you need to be willing to drink with the mayor. So, given that the mayor held the finance of the city, I knew that a few drinks were in order. So I sat with the mayor, had my drinks, and explained to him what the needs of the population in his town. And I do not know how much we drank, but we got to a favorable outcome. So after some time, he then accepted that provide some money for us to build a healthcare facility and to buy medication and diagnose test. Now, full disclosure, the cachaça was excellent. But I'm not saying that cachaça is good. There's no evidence that cachaça is good for healthcare. What I'm saying is that to know a community, get to know the community and the interplay of local personalities, politics, and power is essential to improve decision-making, both in the local and globally. Today, I look at contemporary innovations in guideline developments, and I think what a difference they would have made for the people in Taipei. For example, I really wish we had had this recommendation map for tuberculosis, had access to this when I was doing my internship, preferably if it was in Portuguese. But to inform the many daily decisions that I had to take, I also needed a recommendation map in tropical disease, in tropical and neglected disease, pregnancy and childbirth, and many other primary care conditions. Instead, I could rely only on my textbooks and expert advice from my professors. And early on my internship, a small child came to me with a large mass on the neck for a diagnosis. It was a form of tuberculosis that is called dyscrophula, that is very rarely seen in high-income countries. And I knew that the first step, what I had to do, is to visit his home and understand his living conditions. What I didn't know is what I didn't expect is what I found. The little boy was living with another 20 people, half of them diagnosed with tuberculosis. We had to diagnose with tuberculosis. I knew how to treat them, but we didn't have the resource. And what this experience did for me was really to reinforce the importance of identify ways to improve the conditions of this family, to create a healthcare facility, but also to address the community and make awareness of the importance of social determinants of health. Because these social determinants of health that form the essential piece of the health equity and TB prevention, there are still the same of today. This is recognized by the United Nations Sustainable Development Goals, which include a target to end the global TB epidemic by 2030. The aim is to achieve this through reducing health-related risk factors, but also to increase social protection and universal health coverage. Unfortunately, it is really clear that we're falling short of our promise with this Sustainable Development Goal. And in fact, the COVID-19 pandemic has reversed years of global progress in tackling TB. And gains like improvements in basic nutrition, social care, and housing that helped my small patient and his family are now lost. And similarly, these are happening to other conditions and other areas of the Sustainable Development Goals. In children, globally, pneumonia, diarrhea, malaria, birth complications, and premature births continue to be the leading cause of death. Collective efforts and resources have supported significant progress in under 5 mortality in the past 20 years. And we need to continue working together to maintain these targets. Because at the UN General Assembly in New York this week, it's becoming very clear that for all 17 Sustainable Development Goals that were agreed by the member states in 2015, for most of them, we will not reach the target by 2030. And as the 2021 UN report on child mortality highlighted, a child's chance of living a healthy life is still greatly affected by where they happen to be born. And children born in sub-Saharan Africa continue to face the steepest odds of survival. So in 2020, the under 5 mortality in that region was 14 times higher than North America and Europe, and 19 times higher than Australia and New Zealand. Of course that these figures are extraordinary and that we need to act. And although it might be easy to feel completely overwhelmed by the size of the picture, I think that collaboration, capacity strengthening, and giving people voice are essential to improve these outcomes. And as I mentioned before, there are a number of projects and a number of initiatives looking at these areas. So the recommendation maps is one of them. And I'd like to give you some real-world examples of things that we can do to act. And I want to start by a project called Global Evidence Local Adaptation that is being led by my friend and colleague Tamara. And I'm glad that she's here because if there are many questions, she can answer better than me. But the GALA project is a great example of the way clinical care and Guideline can enhance equity and make a difference locally and globally. So the project is designed to help decision makers in Malawi, Nigeria, and South Africa to develop locally relevant guidelines for newborn and child health using global research. It aims to serve local populations, to strengthen capacity, and to contribute to the global evidence base. Underlying the importance of collaboration, the GALA team is made up of African and international leaders, many of you are here, both in evidence-based healthcare and guideline methods, but they also added the People's Health Movement, a global network of grassroots activists, civil society organizations, and academic institutions, particularly from the Global South. The project team shares Cochrane's vision of a world of improved healthcare, where decisions are made by high-quality, locally relevant, and up-to-date synthesized evidence. And as the aim is to deliver short-term impacts, like new local guidelines recommendation for child health, but also longer-term impacts, like collaborative, multidisciplinary, national guideline groups that build on Cochrane, gene, and grade networks. Another example of global collaboration. Last year, we saw leading health research and philanthropic leaders coming together to share their insights and expertise, both at the WHO Global Evidence to Policy and Cochrane Convened Summit, but also in the report of the Global Commission on Evidence to Address Societal Challenges. Taken together, these forum-related reports provided a comprehensive analysis of evidence usage, evidence needs, and gaps requiring urgent action. And having hosted Cochrane Convenes together with the WHO, we heard loud and clear that concerted action on equity is vital. And in the months that followed, we have been working to address the call to action. For example, the WHO and Cochrane have been working on a partnership proposal to create multi-topic interdisciplinary evidence synthesis units based in and producing evidence for the Global South. And if you want to hear more about that, we have a session at 5. I don't know exactly where, but there is a session at 5. Am I saying that's here? So, because having worked in both regions for decades, what we recognize is that they are comprised of many diverse countries with a varying context and capacities. And local and regional communities need trusted evidence that is easily accessible, relevant to, and produced for their specific populations. We do need to address the issue, the problem that the right evidence does not always reach the key decision makers globally, because decisions being made in incomplete evidence can ultimately harm people. And this brings us to a broader question about capacity strengthening. And the question that I pose to you is, how can we apply an equity lens when developing clinical guidelines and evidence synthesis, or how can we create standards and policies that consistently take equity into account? And this is the focus of the Cochrane and Campbell methods groups, who, among other things, have just published a chapter on the Cochrane Handbook about equity, providing support to authors to increase the awareness of authors in terms of equity. But there is also plans underway to create equity standards and guidance for systematic review authors, and there are many projects like the Muse project that focus on multiple stakeholder engagement, on planning and conducting systematic reviews. And taken together, this work will help build a more inclusive evidence base and increase our capacity to identify and close health equity gaps. We want to deliver resource and evidence that people need, and we want to give everyone a voice. And giving people a voice can be quite literal. For example, last month, we saw travelers from the Global South unable to attend the International AIDS Conference. This is not an isolated case, as many have experienced barriers to attending global health forums. If we want equity, we need everyone at the table. So, as I've tried to say from the beginning of this talk, for me, collaboration, capacity strengthening, and giving people a voice are essential steps to achieve equity, both in terms of who produces, but also who has access to trusted evidence that can guide care, both locally and globally. And you'll be pleased to know that that's my last slide, but I want to finish to thank the organizers for allowing for this discussion. We've seen a number of sessions with discussion on equity, and this awareness is important for all of us. But also thank the diverse Cochrane and evidence community, which I'm very proud of being part of. Thank you.
Okay, thank you, Carla. We have time for perhaps one clarifying question for Carla before we move into our panel discussion.
It was very clear.
It was very clear. Very good. Okay, all right, fantastic. So we'll move into our panel discussion now. I think we've heard some really inspiring presentations, actually. And please, there are 2 microphones here, so please do come up and ask your questions. And whilst you're thinking of your questions, collaboration was a common theme throughout the presentations, that we should be collaborating better. And Laurie, I was wondering if we could start with you. You've obviously got ILCOR and the Council of Resuscitation Councils, essentially. How have you fostered and promoted collaboration across these different groups and achieved this? How have you been able to get all of these groups to agree to collaborate on their evidence syntheses, guideline work, etc.?
I think they want the science. I think that what drives them is, we've heard in all three talks about evidence-based. So to do systematic reviews or scoping reviews is very time and labor intensive. And so this, the councils who want to create the guidelines, they hope that ILCOR will provide them with this feeder of evidence-based, and there are just so many questions that need to be asked that I think what drives them is they send council members, not send because we don't go anywhere, we're virtual. Well, they identify council members to feed into ILCOR, because then there's a connection with the council. So when we finish the systematic review and the data is coming back to the council, there's somebody in the council who's already been in ILCOR, and so there's this communication, the shared experience, understanding, and appreciation for the quality of the methods, the quality of the evidence, and then they're more likely to implement it define the guideline and then implement it at home consistent with the science. So I think the bigger question is, does it cost a lot of money to do this? And it doesn't. Now that we're all so comfortable with Zoom, we accomplish almost everything. All our evidentiary reviews, all our work is all done virtually. So as long as connection to the internet is not inequitably distributed, then we, for the most part, we can collaborate with just about anybody. And I think, and we're all volunteers, nobody's paid in ILCOR, so it's always it's a side hustle on the side of your desk. So you have your real job and then you have ILCOR. And I think we all know that each other have a real job and then we're just collaborating on the side. So it encourages everybody to be kind and generous.
Fantastic, thank you, Laurie. And do we have any other questions from anyone at the moment? Yeah, I can see Nicholas, yeah?
Hi, thank you for some really interesting presentations. My name is Nicholas, I'm a GP from Belgium. And I have a question on the position of guideline adaptation. I think there's been a case made for global evidence syntheses, potentially even global recommendations, but that there is always a place and a situation where contextualization could be possible. My question is, when, or is there any advice from you, when is context important enough to change a recommendation? And when could a guideline or a recommendation that's maybe not congruent with the context leverage policy changes to change the variation in care, for instance? So when does context trump evidence, and when is it vice versa? Is there any advice on that?
Maybe I can start, and start, and then maybe my colleagues can add here. So I'm not specifically a guideline methodologist, but what I also saw during this guideline adaptation processes, that even the opportunity to discuss and see the evidence and to add the local evidence, and even if there was, the context did not require the changing, but even the opportunity to be able to add their own judgments and revise or to see the judgments that were made that enabled them to have more ownership to the guideline development, as well as facilitating the discussion and sometimes I think the contextual factors, there are so many that it's very difficult to answer specifically, but the process to discuss this through and allow them, the guideline panel, to make the decision, that's the value in itself. I don't know if I answered your question, because that was a very specific question, but I think it's also unanswerable, because the context is different and there are so many different factors. There can be values, resource constraints. If you really cannot afford that, of course, then you make the decision to see how you can. Maybe there are others. Anyway, it is a weighing of different trade-offs, which is very context specific.
Come in there.
I was just going to say, I can give an example. So the guideline said we have to cool every patient who has a cardiac arrest who survives and is comatose and arrives at a hospital. Their body should be cooled. So that was the guideline. And I was doing a randomized trial where I was randomizing 57 hospitals to a protocol to try to increase the translation of that science into practice at the bedside. So I was giving them kind of like a KT tool or toolbox or checklist or whatever you want to call it. But before I could even implement the study, I talked to each one of the institutions, and they had taken the guideline and then twisted it, altered it, contextually made it fit their hospital. And sometimes I would look at these order sheets and go, what guideline did you read? Because the protocol or the checklist or the order set or whatever this hospital had done didn't look anything like the guideline. And when you broke it down, because we'd have these wee sessions with the clinician educators and the policymakers and the forms people, we'd say, okay, this, we're supposed to cool to, at that time it was 34 degrees. Why are you giving Tylenol? Or, you know, walk us through this. And that, in that case, you know, context couldn't trump the guideline because they weren't compliant with care. It was a Canadian study. So, but I had to just hold my tongue, because at times the conceptual application of this guideline, if I was going to bring these ICU nurses and ED nurses and ICU docs and ED docs all together to come together to be able to actually improve what they were doing, I couldn't really say what you're doing is not right. So in that case, in just about every hospital we went to, context trumped the protocol because I needed to get them on side. And I think listening to what you were talking about, equity, in Brazil, I was just I was shocked by some of what you were saying, and I thought to myself, it's exactly the same phenomenon. People have to be heard, people have to be listened to, people have to be engaged, and then they'll find a common ground and a common way that they can actually put this in place. And that was a big learner for me.
Carla, would you like to add something?
I just want to add, you know, we're just on the back of COVID. I'm not a guideline developer, but I go to the evidence synthesis side of things. But again, go back to Brazil, the importance of the local context, but also the politics. And we saw it clearly with chloroquine and many other of the recommendations for COVID, that actually I was invited to give a presentation in Brazil about our evidence synthesis for COVID. And I went to the Ministry of Health page, and they had a table that was fascinating, because they said, don't use vaccines, because vaccines were done by the pharmaceutical industry, and maybe it's not good. Use chloroquine, because, you know, we said it's good. So it doesn't matter the amount of information that was available there, but ultimately you have to inform, you know, to use the local setting as your base, because you can provide all the amazing, beautiful evidence, but but still you need to take into account that people's behaviors and people action, it's not necessarily something that we will understand just with evidence.
Zoe?
Hi, Zoe Jordan from JBI. Zach did prep me earlier to ask a question, but this is a genuine question. I do want to thank all of you for your excellent presentations too, because I know that the post-lunch time slot is not always an easy one to fill. So the Global Commission put out a call to action for all of us to consider around a whole range of topics, but the one that I think I've really taken to heart and want us feel that we need to have a global conversation about is prioritisation, particularly in relation to the SDGs, and Carla and I have already had a conversation about this, because most of the work that JBI does and our international evidence network does is driven very much by the needs of the local knowledge needs, and I certainly don't think that that should stop. It's really important work, but I think there's another layer to all of this, and I think there needs to be a global conversation about what each of our respective organisations are doing to contribute to addressing those SDGs, and there's a social responsibility that we all have to contribute to overcoming that, and I'd like to hear your thoughts about how we should take that forward. And I've got some of my own, but I'll save those for later.
Yeah, so
Thank you.
Yeah, we had this discussion, and you know that I'm completely on board with that. I just wanted to add that part of the issue that we had, you know, the good and the bad of COVID was about collaboration, because we saw a lot of duplication of effort. So I really think that certain areas, we're just going to make progress if we can work together. And you mentioned it's our responsibility. So basically, the experiences that I've started this presentation because I wanted to say there are places over there that really, it's our responsibility to work together. So I'm completely on board, and I think, you know, we all have our mandate, but we really have to find ways to collaborate and work together.
Can I add? So yesterday you also heard from Lisa Askey from WHO headquarters that WHO has been asked to deliver less, better. So to complement that, you know, you saw from my presentation that countries are different, their needs are different. So if we prioritize in WHO on our guideline production, and then there are countries who have, in addition to these guidelines needs, then this is where the global prioritization should chime in and to complement that when I'm going to a country and support their guideline adaptation, and then in Tajikistan they ask that we need, our priorities are there and they are presenting the global priorities, then we can tap on other guidelines that can be adapted to country context to complement WHO guidelines.
Rich.
First, I really want to commend the panel and the organizers on what I would call a relentless focus on equity, which is often given lip service at many conferences with a talk and then you forget about it, but it's really in the lifeblood of everything here. And I practice in central Brooklyn, New York, SUNY Downstate, which is arguably the most diverse medical university in the U.S. as far as representation of racially and ethnic underrepresented minorities. So with that said, I didn't think I'd learn anything about equity here, but I've learned a lot. So thank you. But here's the question, and I'm throwing it out there. It's not just for the panel. It's actually for everyone in this room. We talk about equity, and Carla's slide in particular about that conference and the people from the South saying, you know, well, it's not equitable. I ask everyone to look around the room and form your own opinion about racial and ethnic equity and diversity of this audience. I'm not going to say more than that, but I think we need to do better. GIN does have some grants for resource-challenged countries. It's a few. But I think we really need to step up and do something, both as guideline leaders in our own little worlds and societies and parts of the world, to get the right people here. So the people in this audience represent the people we're talking about in every talk. And I think GIN could probably also develop some sort of pipeline programs or grants or ways to build this. Call me wrong, but I'll let you form your own opinions as you look around. So any comments on that are welcomed.
Yeah. I think that's a really good observation, Rich, if I can respond. And I think it's really good that we should be asking ourselves some questions. You know, I think Carla and Marga, your presentations particularly should prompt some reflection amongst GIN and the leadership and the membership as well. And in our strategy, we have said that we want to do more in low and middle income countries, but we're going to need help and advice and suggestions. So, you know, I wonder, do you have any thoughts for us and what we should be doing and how we can improve?
First thing is to say it's not easy. So we've been on this journey in Cochrane from the inset. We have centers in 150 different countries. And I'm going to say something here as an editor-in-chief because I think it's a good, you know, as someone from a developing country, I came to Oxford to work with Ian Chalmers on the early 90s, and it completely changed my personal career. So when I started as an editor-in-chief, I said, that's what I want for other people. You know, very concrete and very simple. Now, COVID came, we speed up all our process, and then we asked people, bring your reviews, we'll help with quality assurance, and we'll publish it on a fast track. It's fair to say that 90% of the reviews we published were from high-income country authors, even with all the good intention, and that's why I think that this collaboration, its capacity strengthening, and is giving people voice, because we're not good on that. We're doing a lot of things, but we still, and I'm talking about Cochrane, have a lot to do to get where we want to be.
Yeah. Thank you. Yeah.
To address equity issues on the task force in ILCOR, they put in place a nominating committee so that you couldn't be a member on a task force without submitting your application to this nomination committee. And this nomination committee had had taken this sort of equity thing to a passion, and they not only did it by sex and gender, but then they did it by country, and then they did it by, not religion, but they did it by country. And there was one more, and what they did was they made almost like a content matrix grid about every applicant to see how they covered all the boxes, and they covered them all in, and that's how they selected people on the task force. So I think from a practical way of doing it, ILCOR has, you know, taken equity and made it a part of the way we practice. Because when you look around at the table on Zoom, when you look at Zoom, they're from all walks of life, and I think that's important. And the only way we did it was to force it. We had to lay it all out, force them into a content matrix, and we had to make it happen that way. In some of our manuscripts, we did authorship exactly the same way, where it just couldn't be the old boys club publishing over and over again. It had to have all these equity parameters were laid out, and so that the author had to fit in this box. What I liked in the third tool they did was all the old boys club that was previously on the task forces or on ILCOR when they first started. They moved them into, what did they call them? I think they're called like senior shepherds or some colloquial thing. They threw them into this sidebar, and they're all in there. They're all in there. There's like 180 of them in there, and senior shepherds. And so what happens is when the 17 members on the task force that fit the content matrix grid, when they're in trouble, they go over to the senior shepherds and get them to help them. And so, I don't know, I think what I was trying to say was, if you don't put your money where your mouth is and lay it out, the surgeons need a checklist to take, to do the right operation. We need a checklist just to get equity right, is my thoughts.
Thank you. And Marga, you mentioned there aren't a lot of GIN members in the WHO areas, and I think made us reflect, yeah.
So as I put forward a call, then why not to win with a country or a society in a low-income country, or to capacity buildings, and so we try from WHO to integrate this into our work, but our capacities are limited. I said it's only me, and there is not much funding, but I think with the passion and collaboration, as Carla has been mentioning, you can take a long road, and then you have someone like Miloslav and Jitka in Czech Republic, and building up the capacities and programs, and so we need to find these people and build their capacities and get the passions, and then they will take it forward. But we need to first find them, but also win them with programs that work, and I try to facilitate to some extent. It's still the first steps, but I have made quite a good connections with many of you and shared my card, and so I may invite you to give trainings or be inspiration or share your country experience. So some of you may get a call or email from me. So I'm really, because you are the guideline methodologists, developers, the leading ones in your society, in your countries. So really, the expertise is here, and so you pass it on, and the ball forward, not only in your country, but maybe elsewhere. Yeah, and it's not only from WHO regional office for Europe, but there are other communities, other platforms. So just need to think about that, as well as think about that not everyone is speaking English at all. How we address these communities and make them aware of what our world is to offer, and there needs to be this translation as well, because I think for many communities or countries, the grade is very intimidating. The methods, the systematic review, it's, oh God, I need to do a systematic review. It's mental barrier. I think we need to also start breaking down these barriers, that actually it is not rocket science. It does not require, it does require resources, but if you're anyway writing a guideline and the leading clinician sits and writes this together, that's also a resource. So it's wasted resource, so why not to channel? But this needs to be communicated in a way that they would want to have that cod liver oil, but in a way that it's nicely packaged. So breaking down those mental barriers, that it is not that it is sophisticated, but it's doable. So these couple of comments on this topic. Yeah, maybe someone got inspired.
Oh, it's fantastic, and thank you, and a lot of lessons, I think, for all of us. Yes.
Yes, hi, my name is, excuse me, my name is Tojo Garami. I work with the Public Health Agency of Canada, and I think like everybody else here, I have found this conference really very refreshing. Just the discussions around equity and, of course, a whole lot more into social determinants of health. But some of my thoughts are around, the fact that COVID obviously was a huge propeller to bring us, where this became in the forefront, because there was a recognition that, it's not just okay to prevent, at least when you're talking about infectious disease, to prevent those diseases that just affect us here. And so there was this realization that if it's transmitting somewhere else, it could get here. And I think this was what, if you look at Ebola and how long that has been around, and what happened with the last major outbreak, and you get a vaccine, right? And you get preparedness and all of those things. So I think if we really reflected, we would say we tend to respond when we understand, well, I think we always understood, but when we see the reality that anything that happens over there could eventually happen here. And so what I think about is how can we move to a place where we don't even see things like equity as something you have to consider in healthcare delivery, but we actually say, should we change the definition of healthcare such that we know that successful healthcare and maintaining good health, these are all the things that have to be in place. And so it's not just okay to give just the medical care that you would give in an acute care setting. It's not just okay. I love the example that you gave, Dr. Is it Claire? Sorry, Claire. The example you gave of that little boy, and just being able to understand where he came from. And even if you treat and you send him back home, what is that environment going to be like? So I just wonder if we can start those discussions. What is the true definition of healthcare? Because the goal is to sustain health, not only to treat. And so, I'm just putting it out there, but certainly these are things that have been going around in my mind. I think excellent discussions, and probably my favorite GIN conference. Thank you.
Would any of our speakers like to respond to that?
I mean, I completely agree with you. I think I just want briefly to say, Cochrane is undertaking a major change on the way we structure ourselves and produce reviews going forward. And one of the things that we're looking at is to create some large themes that are based on sustainable development goals, that are based on burden of disease, but also take into account that is not only the medical disease that we should be looking. So, for example, one of these themes is about mental health and well-being. The other one will be about nutrition and physical activities. So we're trying to, it's its early stage, but I think I agree with you. The most important thing is us to be aware and start thinking together, because there is a lot of people in this room and outside this room that really have amazing ideas and commitment to this. So I wanted to really pass some positive examples, because I think there's a lot of things going on that we just really need to reinforce. I mean, the Gila project in South Africa, Malawi, and it's amazing what they're trying to do with relatively little resource. So we just need to expand and create more of these opportunities, in my view.
I would just challenge that. I think beyond the definition of healthcare, we have to change the way we think about delivering it as well. As in the discipline, the clinical disciplines of medicine, in emergency medicine, for example, which is where I come from, it was easy to always say, oh, that's family practice, oh, that's surgery, it's out of scope. Well, in 2020, there's nothing out of scope in healthcare delivery. We're no longer in disciplinary pillars. We're in this platform, this horizontal thing where we're all in it together, and whether the patient comes in by ambulance or the patient was referred in by a family doctor, and ends up in the operating room, all those different trajectories are all part of one big happy family. And until we as physicians and as clinicians get away from these pillars, this pillar way of thinking, and see ourselves more as the horizontal trajectory, it's going to be hard to get to the where you want to take us, which I agree with entirely, which is, you know, sustainable quality of life. But we have to look at ourselves first and say, I cannot ever say those words, that's scope creep, and that's for somebody else to look after. It's not possible anymore.
Okay, and thank you, Toju, for that comment. Toju also made the suggestion to us the other day that GIN shouldn't focus on health guidelines. We should focus on guidelines that can impact health, and I think that's a really good suggestion, and equity is health, as we've heard a lot this week. Any last comments or questions from anyone? Okay, all right. Well, thank you so much to our speakers for an amazing session. It is time for afternoon tea now. After afternoon break, there is another session. Please do go. I know there is a gala dinner on tonight, but please do support your colleagues for their presentations. And we'll see you all back tomorrow after the gala dinner as well. Thank you, everyone.